afternoon to all. Welcome to our ninth session. Today we are having a topic on non-cancerous illness. It will be taken by Dr. Sunitha Daniel. So we can start with her presentation, ma'am's presentation. We can have it for around 40 to 45 minutes, followed by 15 minutes of discussion. By 4, we can have our case presentation, followed by its discussion. We can wind up our session by 4:30. Thank you all for joining in. Over to Dr. Sunil.
Good afternoon, everybody. So till now we were speaking about cancer and symptom management communication. Now we have to look at the importance of palliative care in non-cancer patients. And if you look at the WHO statistics on who require palliative care, it says major chunk of patients who require palliative care is having non-malignant diseases. So that's the importance of palliative care in non-cancer patients. So this session will be taken by Dr. Sunitha. Dr. Sunitha is from Ernakulam, and she has done her MRCP in general medicine and palliative medicine, and she has been working in UK as well as in India. Right now, she is working as a specialist palliative care physician at Ernakulam General Hospital, and she has been associated with us for a few years. Welcome, Sunitha, and it's over to you.
Thanks, Sunil. Thanks, Palliative India. Is the screen visible to everyone?
Yes, Doctor. It is.
Yes, Sunitha.
Okay. So as Sunil mentioned, today's session will be mainly on palliative care for non-cancer illness. It is a vast topic. There are lots of illnesses we need to cover. So I'll try and go through, most of them, like touch base with most of them, but obviously we won't be able to cover the entire topic in one session. So please feel free to ask questions either in between the session or later on. You could post your comments and questions to Palliative India, and we'll be happy to help you and send you more details. So the objective of today's session is to understand what is the importance of palliative care in patients with non-malignant diseases, and how do they benefit, and how do we identify such patients. And mostly when we think about non-cancer conditions, the important ones that we were thinking of is COPD, heart failure, HIV. So that is these topics I will be covering in the session. So a few words about dementia and other neurological conditions, end-stage kidney disease, and major psychiatric illness and frailty. So before we start the session, I would like you all to think of George. He's 81 years of age. He's a retired teacher. He lives with his wife, Susan, and he had dementia diagnosed about 5 years ago, but he has been deteriorating since then. And now, because of the diagnosis, after 5 years, he's now dependent on all aspects of care. He's doubly incontinent. He has difficulty in communicating. And mobility-wise, he's able to walk only 2 to 3 steps. In the last 1 year, George has been seen by a general physician. He has been seen by a neurologist, and he's been seen by a cardiologist. And he also had 3 admissions to hospitals in the last 12 months for pneumonia. And the last admission actually lasted. After each episode, he did not recover back to the point he was at before. And unfortunately, the last admission, he died on a ventilator. So what do you all think about George? And I'm sure it's a familiar patient. The names can be different, but I think the scenario is quite familiar to everybody who does acute medicine. So just have a few thoughts about George. What all symptoms do you think he must have faced, at least during the last year of his life? What was his quality of life? What do you think was his quality of life? And how was his end of life care? Do you think that was a good death? You know, I'm sure you must have heard the term good death. And do you think that was a good death? And what about his wife, Susan? What sort of bereavement care will she be getting? So I would like you to sort of think about this, these thoughts. And again, you can change the diagnosis to COPD, you can change the diagnosis to heart failure. But again, think of the same thing about the last year of life of such patients. And if you've got some points to comment upon, please feel free to put in the chat box. And during the discussion, probably we can read that and discuss that, or maybe discuss at the end. So these are the, in each and every situation, think about a patient and see how that applies. Whatever we learned today applies to the patient that you have seen before. You must have already been familiar with this definition of palliative care, which was was just told by WHO in 2002, where from 2001, where they've told that the focus is on patients with life-threatening illness and how we aim to relieve their suffering. But things have changed after that, and I'm sure you pretty much have heard about the new definition, which has been coined by IHPC in 2018, where we have got a new term called the serious health-related suffering. So IHPC has coined a new definition. They redefined palliative care in terms of serious health-related suffering, and they've actually expanded it and to cover more conditions. The specialty will now be catering to patients and caregivers of those who have got a serious health-related suffering. And this definition has now been accepted by consensus by most of the palliative care practicing physicians. So which are all those conditions? They've also gone forward and given us a list of conditions, and this has come in the Lancet report also. There are about 20 conditions which they've identified as can cause serious health-related suffering, right from atherosclerosis, cerebral vascular disease, chronic ischemic heart disease, and congenital malformations, hemorrhagic fevers, which we would never have thought that palliative care has a role. But we have seen that all these conditions can cause serious suffering for the patient, which is related to the health. So the WHO feels that, IHPC feels that we need to get involved in the care of such patients. And obviously cancer is still there, but in addition, we've got lots of non-cancer conditions in the list. Now this map is divided according to the income. So it's a World Bank income countries, and you can see that the dark green and the slightly lighter one indicates how the serious health-related suffering is going to change from 2016 to when we reach 2060. And what they say is that this is more relevant for low income and low middle income countries. So you can see India on that, which is darkly shaded, and they've predicted an increase in the suffering from about 155% for the low income countries and up to 87% for the low middle income countries. So when we reach 2060, whatever suffering or whatever the percentage of patients that we have got right now is actually known to drastically increase and drastically change. So the need for palliative care becomes all the more relevant. And again, this is the same list that I told you about. Here we've got you can see number of patients who are dying because of the conditions mentioned. And you can see that the predicted number of deaths, again, due to various conditions, is also now it's expected to shift. And the malignant condition, as before, is topping the list. But in addition, it's expected that the number of deaths because of CVA, because of lung disease, because of dementia will also increase by 2060. And this is another graph which shows, again, the cause of death. So the right on the top on the yellow is the injuries. The red one is the communicable diseases, the maternal death, nutritional diseases, and the blue one is the non-communicable disease. And you can see how the pattern of deaths have changed from 1990s to 2016-17. So the communicable disease have come down, the NCDs have gone up in diagnosis, as well as the cause of death has changed over the 20 years. This is what we see all around the world, and it's similar to what we see in India also. Again, we had, compared to the rest of the world, we probably had a lot of communicable disease in the past. So our numbers of communicable disease is also coming down, but you can see that our NCDs is also going up. Now, and this is a growing burden as far as our country is concerned, because it's actually mirroring what we see in the developed countries. So India is actually facing an epidemiological transition. There's a growing burden of NCDs coming up, mainly because of the lifestyle is changing. We all know that we've got the lifestyle diseases are coming up, unhealthy eating, because of excess alcohol, because of physical inactivity, the tobacco use. Our NCD burden is increasing, but at the same time, we still have got our infectious disease, which we haven't got control over, or complete control over. So every time, at least in Kerala, we've got, every time there is a rainy season, we get a dengue infection. All these infections are still there. So whatever money the government is spending on has to be spent on both the communicable and the non-communicable diseases. And the other thing to remember is that the patients who suffer from this chronic NCDs actually get diagnosis quite earlier on. And therefore, it's a challenge for them because we have to look after them for a long term. So that's an increasing burden that our country is facing because of the change in the epidemiological shift of the diseases. The ICMR has states that about what they're predicting is that about 40 to 75%. Data from 2017 showed that the disease burden, about 40 to 75% of the current disease burden is NCD. And the highest number is coming from the state of Kerala, Goa, and Tamil Nadu. The lowest number comes from the state of Bihar, Jharkhand, Uttar Pradesh, and Rajasthan. So this data is from the ICMR, which was published in 2017. Now, this is one of the studies that I was involved when I was in the UK, where it was a retrospective study was done. We did an analysis of the community and the hospital palliative care provision in a large city in UK. And this was published in 2016 in BMJ Open. And what we did was we analyzed the number of referrals that is coming to palliative care from the community and in the hospice. And we analyzed about 4,000 patients, which was included in the analysis. And what we found that only 700 had non-cancer diagnosis out of the whole 4,000 that came to palliative care. And the median duration of palliative care involvement before the death was about 16 days. So, ideally what they say for cancer, what they say is at least 6 months before death, you have to be referred to palliative care. So UK is one of the countries where palliative care is most developed, and you can see that the data still is very poor, especially for non-cancer. They're not referred enough and they're not referred on time. Now, why is it important? Why do we want to get palliative care involved for non-cancer condition? Why do you think it's important? So if you remember George, who doesn't have a cancer diagnosis, but if you can think of his symptoms and you can understand that these are the common symptoms that you must have learned in cancer also. So paper published in 2006 in JPSM by Solano et al. Have shown that pain, breathlessness, and fatigue are very common in advanced cancer. But in addition to that, it's also common in AIDS, heart disease, COPD, and renal disease, which are the non-cancer conditions. So what is going to happen is if we don't identify that, or if the treating physician doesn't understand that and identify that, all the non-cancer patients will not be referred to palliative care and they will have poor symptom control at the end of life. But for cancer patients, like everybody knows that palliative care has a role in that. But unfortunately for non-cancer, that is not a well-known knowledge. So if they are not referred on time, those patients tend to suffer. And I've got the same paper, I've got the list of symptoms. So as I mentioned, dyspnea, pain, fatigue, depression, and you can see how common these are. So obviously for COPD patients, about 90 to 95% of patients can have dyspnea towards end of life. But if it's lung cancer or any other cancer, it's 10 to 70. So breathlessness is, it's more common in heart failure, which is 60 to 88%, and COPD as compared to the cancer counterpart. So if those patients are not referred, they are going to suffer. Similarly, all the other symptoms, you can see how high fatigue is there in heart failure, 69 to 82% of fatigue is there. Again, anxiety in CKD patients, 39 to 70%. Anorexia in cancer patient, 30 to 92, but also in COPD, that is 35 to 67%. So all the symptoms that we know about in cancer patients are seen in non-cancer conditions also. Now, this was another study which was published in 2000 in Thorax. Again, this was also published quite early on, which compared the quality of life in end-stage COPD patients and lung cancer patients. And it showed that patients with COPD had poor quality of life and more breathlessness compared with those with lung cancer. But none of the COPD patients received any specialist palliative care services. So, obviously the cancer patients are known to get referred to services, but COPD patients seem to have more symptoms, but they're not being referred on time, or they're not being referred to the palliative care services. And similarly, there was another study done, a prospective cohort study was done, from on seriously ill patients, hospitalized patients with COPD and lung cancer, and they were asked about what was their desire. The advanced care planning was done. So equal number of patients in both the groups, they wanted supportive care and did not want ventilation. But eventually, when they continued to do the study, what they found was eventually more patients with COPD received ventilation as compared to those with the lung cancer. So obviously, even though as a part of study, this question was asked, this was not translated into clinical practice. So more COPD patients, 70% received ventilation as compared to 20% of cancer patients. So what do we do then? So how can we help these patients? So this is a comprehensive approach to management of dyspnea. So, if you get a COPD patient, if as a palliative care physician, you get a COPD patient earlier on, so what do you do that? How do you manage them? So you can see that as the magnitude of dyspnea changes, the management therapy will also change. Initially, we can give them bronchodilators, so short-acting bronchodilators. You can give them long-acting anticholinergics. You can give them long-acting bronchodilators, inhaled corticosteroids, which is a standard therapy for all COPD patients. And you can see that step by step, as the disease worsens, the pulmonologist would have started all of this treatment for them. And then they'll reach a point when you can't give any more disease modifying or disease modifying treatment, and they're still breathless. So there's an entity called chronic breathlessness syndrome, where you can see that it can be breathlessness can be because of any cause, either COPD, either heart failure, or even cancer, where they're on the maximum treatment, medical treatment possible for their breathlessness, and they're still there breathless. So they go on to they continue to be breathless, and then you go on to the next step, where you can initiate and optimize a non-pharmacological management. So there are palliative care physicians and nurses and physiotherapists who are trained to teach the non-pharmacological technique of management to these patients. Exercises, handheld fan, pursed breathing, walking aids can be used, and all these can be tried. And again, they're still being breathless. Then we can start them on short-acting morphine. So this should be covered in breathlessness management when you have the session breathlessness, but you can start them on either short-acting morphine, and then you can change them to long-acting opioid therapies for breathlessness. And then they go on to the end-of-life care. So our input has a role earlier on in the symptoms and as well as towards the end-of-life care. So that was about COPD. Next, we come to heart failure. Again, data from UK shows that incidence of heart failure is 1 per 1,000 population per year in UK. And they unfortunately do have worse survival as compared to breast or prostate cancer. But many of us don't realize that. Many of us as doctors and even patients don't realize that. If you have got a problem with your heart and your heart is failing, nobody thinks that as a like life-limiting diagnosis. They are happy to continue taking medications and go on with their life. But if you get a diagnosis of cancer, then that's it. Your life is finished. But actually, survival rate of heart failure is found to be worse than breast or prostate cancer. And what they found, again from UK, is that half the patients diagnosed with heart failure die within 5 years of the first hospital admission. So if the heart failure is bad enough to require a hospital admission, then they could die within, the prognosis is poor, they could die within 5 years of first hospital admission. Now, the other thing to remember about them is that 1/3 to 1/2 of patients might have a sudden death, irrespective of the heart failure stage. So that is why all the more it's important for us to give them a proper symptom control and advanced care planning. So that's very, very important to tell the patients that they are aware of the fact that they can potentially have a sudden death. So again, another one, if you are dealing with a heart failure patient as a palliative care physician, so what do we do? So you must have heard of all this, classification. You've got NYHA, New York Heart Association classification of heart failure, as well as we've got American College of Cardiology and American Heart Association, AHA classification of heart failure, where they've divided into stage A, stage B, stage C, and stage D. While the NYHA, which I think most of us are more familiar with, is divided into class 1, class 2, class 3, and class 4. Now, the reason I'm mentioning this is the medications that we are using for heart failure. The other important thing to remember is there is a misconception that once palliative care starts, you stop all active treatment and you stop all the other medications and you only concentrate on symptom management. This is true, but in the case of heart failure, the role of the disease modifying agents or medications that the cardiologists prescribe do have a role towards end of life. So depending on the class, so if you've got NIHP class 1, then there is a role for ACE inhibitor, which is shown to improve the survival and decrease hospital admissions and improve the functional status, which has to be continued till when they are in class 4. Then in class 2, you start with diuretic. Then beta blocker again has a role from class 1 to continue till class 4. Similarly, mineralocortical antagonists, you start in class 2 and you continue till class 4. And digoxin, again, you start with class 3 and you continue to class 4. So all these are important. Again, most of them can improve the survival also, and they can decrease the hospital admissions and increase the functional status. So it's important for us to also remember that we shouldn't be stopping any of the cardiac medications unless there's an absolute contraindication, or you can say that, the BP is dropping drastically, patient is having dizziness and not able to mobilize because they're on medications. Then probably we should be thinking of, so you have to have a risk benefit balance and could consider thinking of stopping this cardiac medication. Otherwise, they do have a role even till end stage to help them in the symptoms. So next entity is end stage kidney disease. Now, which all patients in end stage kidney disease can benefit from palliative care? So there could be a group of patients who might not choose. They either, they are advised, there is a stage when they have to go into dialysis, but they decide not to go for dialysis due to any reason. It can be financial reason, it can be that they don't want dialysis because it's actually affecting their lifestyle. They have to probably go to the dialysis unit 3 times a week, and some people don't want that, or they've been told not to start on dialysis. That's one group of patients. The other set of patients are those who are failing to thrive on dialysis. So they're going for dialysis, they're having thrice weekly dialysis, but this worsening quality of life and this increasing symptom burden despite dialysis, then the palliative care has a role. And those patients who discontinue dialysis, definitely, palliative care has a role. But unfortunately, again, one of the studies done in UK have shown that if they're on long-term dialysis for more than 1 or 2 years, once you discontinue diagnosis, the average lifespan is actually less than 10 days. Though there are patients who have survived more, but they do become symptomatic quite quickly because they're dependent on dialysis so much that they could die pretty quickly. And so they can reach into end-of-life care at that point. So these are the patients which can benefit from the palliative care environment. Also, those who can have extremely poor quality of life and needing frequent hospitalization. And what happens is, just I mentioned about heart failure, the end-stage kidney disease, also the prognosis is comparable to that of the common malignancy. The quality of life is very, very poor. And they can have all the symptoms like dyspnea, confusion, pain, anxiety, and depression is very common during the last few days of life. Again, another study from the United Kingdom. This was done, this was a retrospective observational study, again published in 2013, which compared the survival and the palliative care involvement of 2 groups of patients. And these 2 groups of patients were about 70 years. Now, these 2 groups of patients were, have reached a stage when they've reached end-stage kidney disease and were supposed to be starting dialysis, but one group of patients chose conservative management. The other group of patients chose dialysis. So when they found, what they found in the study was that when they analyzed data, what they found was they compared the survival and the hospital admission and the palliative care access. And what they found was patients who over the age of 80 with a poor performance status and with a high comorbidity scores survived longer when they chose conservative treatment as compared to dialysis patient. And expected dose in conservative dose has more access to palliative care. So this study was done for patients above 70. So there are 2 groups, one above 70 went for conservative route, the other above 70 went for dialysis route. When they analyzed the data, the survival advantage was found in the patients over 80. So those patients over 80 who did not choose dialysis but went in the conservative route. So those patients who went in conservative route had regular follow-up with the palliative care physician. So whenever they had issues, they did not go to hospital, they went to hospice. So they had regular input from the palliative care team. And they had regular symptom management also. So what they found was such patients actually lived even longer if you're above 80. So survival advantage of a dialysis is lost when you're above 80. So those people live longer if you're not taking dialysis as opposed to those who are above 80 who took dialysis. And this was actually a very landmark study, as well as the management palliative care in UK was and subsequently lots of combined clinics were started in different parts of the country, depending on based on the results from this study. Okay, coming to HIV or AIDS. Here we all know about how AIDS have changed. When early in the epidemic, HIV infection was considered to be a speedy death sentence, and because things were changing quickly, palliative care was only during end of life. Now things have been changed. The survival of HIV with heart treatment, they can even have a near normal life expectancy. But still, palliative care has an important role in managing the symptoms. So what sort of role do you have? So this is a chart. Again, you must be familiar with this trajectory of illness chart, where you've got different charts where chronic diseases have got can come down and patients can deteriorate. There's a dip in the graph, but they can get better and they can continue for some time, have a dip in the graph again. So and they sort of have a weaning off period, and finally they end up dying. But as opposed to cancer patients who would be stable for some time and suddenly have a dip and probably wouldn't come back to the baseline and have a quicker death. So what you found is that AIDS in the heart era is come back to the chronic diseases like congestive heart failure or chronic COPD, where you could go on for some time and die towards after some time like a chronic disease. So in which all ways can we help? What are the needs of palliative care in HIV/AIDS complex? So it is a multifactorial disease, and it's like a chronic disease in an aging population. So you can see that there is increasing needs. It's a multidisciplinary needs are there. Like any other chronic disease management, there's a role of palliative care in managing these patients. You can have any sort of age-related changes. So the morbidity, age-related morbidity can be there. There's frailty. There can be premature aging. You have to look after the polypharmacy of end of life. So like in any other aging population, but having an HIV diagnosis. Now, HIV infection can cause chronic immune dysfunction and sort of inflammatory changes. So that can have problems. Patients can have a non-AIDS specific comorbidities. So you can have they can have AIDS defining malignancies. They can have cardiovascular comorbidities or pulmonary comorbidities. That will need input. Some of the drugs itself can cause some toxicity. So you could have symptoms because of that, because of drug toxicity. Then the patients can have their own psychosocial issues. So they could have problems with substance abuse or mental health problems or social isolations. And also the other environmental stresses. There could be environmental issues like poverty or unstable housing and unsafe environment. So all these then similarly the slide that I mentioned initially, the symptoms like pain and other symptoms, anxiety, everything is common in AIDS patients also. So there's a lot of things, a lot of changes that you can make if you can refer the patient to a palliative care team. Okay, coming back to George. So advancing dementia. What are the common symptoms you can see? So it's again, all are familiar to us. Confusion, which is the most common one because of disease. 83% of patients with advanced dementia can be confused. They can be urinary incontinence. Pain is also very, very common, 64%. People can have low mood, can be depressed. Constipation can be a major issue, and loss of appetite. So again, similar to a cancer patient. So they also have got a myriad of symptoms towards in advancing dementia, which will need the input from the palliative care team. I would like to mention a few of the assessment scales that you can use to functionally assess a patient with dementia. So we all know about the diagnosis of dementia with the memory scales and the mini mental scale examination to diagnose the mild, moderate, and severe cognitive impairment. Once they have got a diagnosis of dementia, there are a few scales of measures that can be used. Which one of them is called the FAST scale, which is Functional Assessment Stage Scale. The others are Clinical Dementia Rating Scale and Global Deterioration Scale. So FAST is a 7-stage system, and it's based on the patient's level of functioning and the ability to perform the ADLs, activities of daily living. rather than the cognitive decline. So it basically tells us a dementia patient, how bad is the function, and you're scoring them depending on that. The FAST scale has got 7 stages. 1 is a normal stage, like a normal adult. Now, 2, you can say it's a normal older adult. 3, if there is a stage 3, it's early dementia. And 4 is mild dementia. 5 is moderate dementia. And 6 is moderately severe dementia. And 7 is severe dementia. So what happens in each of this is given in the table. So you can see that there are initially there will be few impairments of, daily activities. Then they'll have problems with difficulty dressing, bathing, toileting. Sorry. Bathing and toileting, and then finally speech is affected. In the end, with the 7C, 7D, 7E, so they're not even able to sit up without assistance. Smile is lost, whole head up is lost. That's how they progress, and that's how you scale the patients. The functionally, how the function is changing, and when you reach stage 7, which is divided into A to F, they reach a stage called severe dementia. So in stage 7, the speech is limited to less than 6 words per day. And they can't walk. This inability to ambulate independently. They can't sit up without assistance. They can't smile, and they can't hold head up. So this is an important, I think, a good tool to remember, especially when you're seeing dementia patients, for us to know how bad the dementia is functionally. And so, again will tell us what all help they need, in what all cares and what all help they need. And what all can you do in dementia patients other than symptom control, which I've mentioned. Advanced care planning is very, very important. So why is it important? Think about George. In the last 1 year of life, how many hospital admissions he had, how many times he was admitted to ICU, and unfortunately, he ended up dying in a ventilator, which should have been completely avoided if there was proper advanced care planning. And its aim is to avoid the potentially burdensome treatment. If there is a palliative care facility available, like a hospice or any inpatient facility, these patients should be referred there if they've got issues. So what happens towards the end is mostly infection, isn't it? They could aspirate, they could have an aspiration pneumonia. So infection is the most important thing that could be the terminal event also. So you can decide whether you need to give antibiotics or not give antibiotics. If you're giving antibiotics only for symptom control, that is allowed. But ideally, you should be given a ward-based situation with the family around, so that he doesn't become more confused and agitated in an ICU setting. So advanced care planning is very, very important. And if the treating physicians are not able to do that, please refer to the palliative care team, and they can get involved in and giving all the support. And also the bereavement care and the caregiver support is also very, very important. A few words about the other neurological disorders other than dementia. You've got motor neuron disease or amyotrophic lateral sclerosis, Parkinson's syndromes, multiple sclerosis, ischemic and hemorrhagic stroke. Lots of neurological conditions are there where early palliative care is quite important. And I'm pleased to say that neuropalliative care is an emerging sort of like a special interest group in India, where we've got consultants like Dr. Roop Gursahani, who's an eminent neurologist who's got special interest in Parkinson's disease as well as special interest in palliative care. And they did the first CME on neuropalliative care quite recently in Kochi. And it's sort of like an emerging sort of subspecialty in palliative care now, it's like a progressive or promising future for palliative care in India as far as the specialty is concerned. So some few words about some medications which can be tried to symptom manage with common symptoms in neurodegenerative disorders. It's nothing different to what you've learned before. You can, common symptoms I mentioned, if you've got constipation, dyspnea, the anxiety related to that, fatigue, muscle cramps. So all the medications you can try, which you have learned for symptom management for a palliative care, can be tried here. So you can try opioids for dyspnea. You can try the different types of laxatives. You can try benzodiazepine for their dyspnea-related anxiety. Muscle cramps, quinine sulfate is very good for that, 200 mg per day. Pain, again, follow the WHO ladder and prescribe accordingly. The other symptoms like pseudo hypersalivation, you can try buscopan or amitriptyline. Psychosis, agitation, irritability, you can try quetiapine. One of the common things that we use in palliative care. If the sleep disorder changes, clonazepam can be tried. You can try melatonin for sleep behavior disorders. Respiratory failure, again, advanced care planning is very, very important. Always have a discussion about who is the best candidate for having a non-invasive ventilation or not, especially in motor neuron disease is very, very important. Tracheostomy, if needed or not needed. And then symptomatic treatment, you can always use opioids, just like any other dyspnea management. Other symptoms like sleeplessness, as I mentioned before, then spasticity. You can try baclofen, tizanidine, secretions, thick secretions. Mucolitis can be tried, and other supportive measures like nebulized saline and manually assisted cuffing techniques and modified postural drainage, humidification extra can be tried. Coming to the next topic, which is frailty in old age. Again, our geriatric population is increasing, and by 2050, what is projected is that about 16% of world's population will be over 65, which is about totaling about 1.5 billion people, compared to 1950, which is only 5%. So what happens when you've got an elderly population? Obviously, the disease conditions will also change, and there's some natural progression of old age in a development where it's called the frailty, where they've got a diminished capacity to withstand stress. And when you're very, very frail, there's increased vulnerability to adverse outcomes. They are also physically disabled, and they can have impairment in activities of daily living, this social withdrawal, slow motor processing, cognitive changes, weight loss, or negative energy balance. All these can be seen as a natural process in elderly, and is identified. And it's important to identify them earlier on, because of all these factors, they are of increased risk of falling down, there's increased risk of hospitalization. And if you actually interfere earlier on and prevent frailty in these elderly adults, 3 to 5% of deaths in older adults can be delayed if frailty was prevented. So how do you do that? Again, primary prevention would involve addressing the comorbid illness like hypertension. Secondary prevention is all the chronic disease management, exercise and nutrition. And tertiary prevention would involve, so that will be basically will be identifying the frail individual, providing a good palliative care, maintaining and improving function, so like regular exercises, controlling the symptoms, maintain the psychological well-being, and preventing hospital admissions. So so basically the major problems with elderly, the problems, if you can manage certain symptoms at home, it's all the more better than admitting an elderly patient to hospital, because they tend to get more resistant organisms and infections from the hospital than they do from the community. So it's always better to identify the frailty in an older individual, and do the primary prevention, secondary prevention, tertiary prevention, and including a good palliative care, and maintain and improve the functions, control the symptoms, and maintain the psychological well-being and prevent the hospital admissions. I wouldn't go into details into the major psychiatric illness. I'm only mentioning is because it's important to understand that, especially with cancer patients also, it's quite prevalent, especially depression. And 38% of patients in oncology can present with depression. The depression that comes in oncology patient actually comes under a different criteria of the coding of diagnosis. It's DSM-5 criteria, where there's a direct physiological result of conditions. So another medical condition causing depression. So you can have hypothyroidism or chronic uremia, or presence of cancer-induced cytokines, or medication effects of steroids. All these can cause depression. So this depression in oncology or major psychiatric illness, it actually comes under DSM-5 category. Again, it's very common, so it's important for us to, what is the consequence? So why do you have to identify depression in cancer patients or advanced disease? It's mainly, one of the important things to understand is the, compliance to medications. Because of depression, it can affect the treatment adherence. So they can have reduced understanding about the disease. Because of that, they can refuse to take treatment. And there can be decreased motivation for care and healthy behaviors. They even have poorer tolerance of side effects. And because of the isolation, they can have poor family support, and that will lead to greater isolation. So it's important for us to identify that and even treat that. Again, screening for depression, I wouldn't go into details on that. There are various screens that can be used. Distress thermometer is something that NCC and the National Comprehensive Cancer Distress Management Panel is there. And they actually have recommended periodic screening for all the patients by using various tools. Or you can even use a single question. Do you feel low in mood? What is your mood? Are you depressed? That is, even a single question is also supposed to be highly sensitive in identifying depression. I'll just quickly mention the pharmacological treatment of depression. Again, nothing new. These medications, palliative care team is actually quite familiar with. The doses are different. So tricyclics, if you're using for depression, you need to go for a higher dose, about 25 to 150 milligram. We don't use that first line for depression anymore. We usually start with an SSRI, so citalopram or fluoxetine, or you can even use SNRI like venlafaxine, duloxetine. Then there are newer ones which is quite popular in palliative care is metrazapine, which is a noradrenergic and specific serotonergic antidepressant. It has got lesser side effects, and in palliative care we use that for depression, anxiety, appetite and weight gain, and insomnia. I'll just mention about a few points about what do you think is the barriers. So why doesn't any of these non-cancer patients get palliative care input? So this support study was a study to understand the prognosis and preferences for outcomes and risk of treatment. And they found that the doctors feel there is a prognostic uncertainty, because sometimes they feel that the patients with heart failure, when they thought that the support study, what it found was that patients with heart failure, they were predicted to have a greater than 50% chance of survival for more than 6 months, but they died 3 days later. So this was published, and this again shows that how much uncertain the prognosis is. So this is one of the barriers that was found as far as doctors are concerned, because they're not sure whether the patient is ready to be referred to palliative care or not. So not knowing how long the patient will live will create an uncertainty which paralyzes the doctors, and they potentially prevent them from seeking palliative care. Also, they feel that what the doctors feel is that they would like to be optimistic. So they don't want to alarm the patient with the thoughts of, because palliative care is equal to death. So they wouldn't want to alarm the patient with the thought of impending death. Again, there are things that, like some professionals would feel that death is a failure, and if you accept palliative care, that means they have failed as a professional. Sometimes they wouldn't have enough palliative care services nearby, so they wouldn't be anybody to refer to. And again, as far as patient and family is concerned, there are some barriers, like patient feels, I don't have cancer, so why should I see a palliative care physician? Sometimes they fail to recognize it's a terminal illness, and they wouldn't want to accept that it's a terminal illness. So, so how can we help these physicians? How can we help them to identify this patient? When can you refer to palliative care? This is an important tool that is again quite recently developed, supportive and palliative care indicated tool, or a SPIC tool. It's useful for identifying patients with advanced life-limiting condition. Now, this can be cancer also. So it can be any conditions where they receive appropriate care according to their need. So this tool is, if you can find this in the internet. It's a very useful tool, and they've given for each condition. So for cancer, they've given how do you identify when they've reached advanced stage. For dementia, frailty, for neurological diseases, heart, vascular diseases, respiratory disease, kidney and liver disease. So everything, they've given some guidelines for the physicians to follow to identify that there's a palliative care indicator or need is there to refer the patient. So heart and vascular disease, what they've mentioned the SPIC tool is NYHA class 3 or class 4 heart failure. If it's liver disease, these are the criteria: advanced cirrhosis, hepatic encephalopathy, hepatorenal syndrome. So once a patient reaches stage, then probably it's better to refer to the palliative care. Kidney disease, stage 4 or stage 5 chronic disease, EGFR less than 30, stopping dialysis. I mentioned all this before. So other thing that is recommended is that it's a surprise question. So if imagine you're seeing a patient in an OPD and you ask yourself this question: is this patient likely to die within next 12 months, or would I be surprised if this patient died in the next 12 months? So if I look at a patient and say, would I be surprised if this patient died in the next 12 months? If I am not surprised, that means he's likely to die in the next 12 months, then he needs palliative care. So that is a surprise question which is recommended for all the advanced care planning discussion, irrespective of diagnosis, irrespective of symptom. That is a need. So that is another important thing that has come up quite useful. So to conclude, and I agree, it has been a very quick session, trying to cover all the points, but the message that I would like to convey through the session is that for you to understand that palliative care is needed with any patient with serious health-related suffering, which can include both cancer and non-cancer. And there is still a need for further research into the needs assessment tool for specific conditions as well as the evidence of benefits of palliative care involved. I really need to get this. Hold on a second. Just take it. Okay, thank you very much for the session. There will be a feedback that will be sent to you by Rajalashmi as an email. It's in addition to the usual feedback from DECO, which is a Google form. It's personal feedback for my session. I'll be really grateful if you can answer those questions. Thank you very much.
Thank you, Sunitha. So we have had a elaborative talk on non-cancer palliative care. She tried to touch upon the diseases which we can see in palliative care. So you can ask your doubts.
Sir,
Okay.
I have a doubt. I'm Dr. Nilofer. I had a patient who had Sjogren syndrome, and she was close to 75 years old, 75, 76 almost. And she also had comorbid disorders like she had heart failure, she had severe anemia. Now she came to me with the complaint. I'm an oral medicine specialist. So she was brought to me with the complaint of severe dryness in the mouth. Severe dryness. So the only thing that I could suggest to her was symptomatic, that is sipping up of water frequently, or placing some lemon juice or things like that. So I was not in a position to manage her dry mouth at that situation. Could you please suggest what could be done in such patients?
So dry mouth is again very common condition, both cancer and non-cancer, and not very easy to manage. First thing is mainly look for any other obviously Sjogren's, I think dryness in that is related to the condition, but make sure there's no thrush, oral thrush, or anything else happening. Get your nurse to or anybody to advise on proper mouth care. Because you can have problems with dry mouth and can lead to ulcers and everything. What you have done, the simple measures, there has been a literature review about all the medications, and none of them. So what all have been tried is you can have artificial saliva. So this oral balance gel and artificial saliva is available. Pilocarpine tablets, again, to stimulate the saliva, or simple things like chewing gum, boiled sweets. Pineapple is supposed to be really good. So what the literature review has found no evidence for any of the medications. The most evidence is actually for simple things that you've been doing. So ask them to chew on ice cubes, or use some chewing gum, or that stimulates the saliva, or boiled sweets. And pineapple chunks are quite good to promote salivation. So all these things are the only ones that we have been trying. Anything else, Sunil, that you can think of?
No, Sunitha, I think that's a very good description of how to treat dryness of mouth. Anybody else? If you have any doubts, you can put it in the chat box also. Anybody? At what stage COPD should opioid be introduced?
So
Sunitha?
it's, yeah, so if you remember that table that I showed you, so probably the second or third step where basically they've got all the medical treatment for COPD. So all the inhalers are there, and they're still breathless. Then you can try with the more non-pharmacological techniques that I told. So all non-pharmacology should be taught earlier on before you introduce opioids. So if there is a good, a physiotherapist who can teach non-pharmacological techniques, then ideally that is a better one. You can get them handheld fans. So there's some, you can get small fans available in even through Amazon. Sometimes you can get that, which is like you hold it close to your face, and it stimulates the trigeminal nerves apparently and actually decreases sensation of breathlessness. So you could give that to a patient when they get a bad episode of dyspnea, ask them to use this handheld fan, and that seems to work. And even when that, so basically it's for chronic breathlessness syndrome. So any cause of breathlessness, patient is still breathless in spite of optimal medical management, and you can't manage breathlessness. So that's when you think of giving opioids. And morphine is the one that has been, trials have been done on that, and it's very useful for that. And what we normally advise is you start with short acting morphine. So I usually suggest for 2.5 milligram tablet. So 1/4 tablet, you can give it 3 times a day, and SOS if needed. And if long acting is available, you can switch to that depending on the needs. Normally higher dose are usually not needed. Maximum up to 15 BD or 30 milligram is usually that's given in clinical practice. So as we said, when you have breathlessness that is not responding to any standard, all the maximum medical treatment, it's not responding, you can start them on opioids.
So Sunitha, there is a comment saying opioids can cause worsen respiratory failure in COPD.
So it's not that is a misconception that we all had when we were in medical college, and when we all learned that, but that's completely changed now. There are lots of trials available, especially in COPD patient. I can actually send you the link of the trials. The randomized control trials are available, and it doesn't worsen respiratory failure. It's actually given low dose. The dose that we give is actually given for COPD patients and improves the breathlessness. In fact, I've had patients who's been on NIV because of very bad dyspnea, and even on NIV they couldn't control the breathlessness. So basically, the whole idea is to decrease the sensation of breathlessness. Patients become less aware of the fact that they are being breathless. So it's a symptom management thing. And these patients on NIV, when I started them on morphine, we were able to wean them off the NIV, and they went home on morphine and home oxygen. So I can send you links to the article if you want to go through that. But that concept, the concept of opioids worsening respiratory failure in the dose that we give, has not, it's not there, and that doesn't happen. Again, Sunil, you want to add to that?
No, I agree with you that even many pulmonologists refer patients with COPD, and there are some pulmonologists who also work in palliative care who use opioids for treating very severe COPDs. So it is very important, and we have evidence for that use of opioids in refractory COPDs so that they will have a good quality of life. Even we have patients who have severe COPDs and who are very comfortable on morphine small dose. So Sunitha, you have Sunitha is working, as I told you, in general hospital where they are seeing a lot of patients requiring palliative care. So if you take the percentage of patients who require palliative care if you divide it into non-cancer and cancer patients, how many percentage of patients would require, how many percentage of non-cancer patients would require palliative care? What's your experience, Sunitha? And how difficult it is to convince them regarding the scope of palliative care in non-cancer palliative care?
Yeah, unfortunately, so in India, I've worked in both a private hospital. I was in Amrita before, and now in General Hospital. So I think what I would say is both the person is very, very poor. I'm sure I've done a similar study, but this UK study, I've actually done it in Amrita. And in Amrita, I think for non-cancer, you get for pain management. So you get some of the consultants in non-cancer would send patients to us for pain management. So such in that way, the number has gone up. And then towards the end of my time there, we started getting patients for breathlessness. So we had another discussion with the respirators. We went and told them, the consultants, pulmonologists, about the role of morphine, and then we started getting patients for breathlessness. We used to the only non-cancer probably in General Hospital, or I would say, is IP. It's very rarely you get patients. So non-cancer things that you can get is maybe stroke, a bedridden patient, paraplegia patient, for bed sore care. You can get that. That is common in community also. But if you consider COPD or heart failure, you hardly get anything. Heart failure, you hardly get anything, even in a private hospital or in government hospital, because they're not aware of that. Basically, that's the thing. Yeah.
Yeah, so the problem is that even all of you know that if you look at the palliative care scene in India, most of the palliative care units are in Kerala, and rest of India has less palliative care units. But even in Kerala, if you look, I think most of the palliative care units are seeing all type of patients, both cancer and non-cancer palliative care patients. When we took our statistics about it's 50-50. 50% of patients are having cancer and 50% are having non-cancer diseases. But all the cancer patients are not coming to any palliative care units. So we even now we have reduced awareness regarding palliative care. So in such a situation, it would be very difficult to convince our colleagues regarding the requirement of palliative care in non-cancer patients. So that's one thing. So from the professional side, there is a barrier. So but now people are becoming more aware about the need of palliative care in non-cancer patients, so that some patients by themselves or patients peer referral is also happening. So that's a good sign, but I think we have to our colleagues have to be more aware about the need of palliative care in non-cancer patients.
There was another question in the chat. So I've sent you a link for one of the literature review. It's published in 2015. There's lots available. If you just put opioids and breathlessness and search, you get lots of papers. So how long can morphine be continued? Now that's a good question. So morphine for pain, again, for chronic non-cancer pain as such, we don't normally suggest morphine. For cancer pain only we usually suggest. When the pain is better, we ask them to discontinue morphine. But if they are end stage, end of life, and then dying, then patients still have got pain. We don't discontinue morphine. You can give it, till they have pain. So basically, if they've got pain or they've got symptoms, you can continue the morphine. Similarly, for breathlessness also, usually when they reach intractable breathlessness is when they reach into end-stage COPD. So if that's the case, then we don't, if it's giving benefit to them, we don't discontinue the morphine. We can continue till they have symptoms. Now, another question, again, Sunil, please comment additionally if you want to. Patient is end-stage renal disease, can we use morphine? So that probably is not advisable. I mean, so he's on dialysis, but the thing is that morphine can accumulate. So ideally, if EGFR is less than 40, this is ideal situation, I'm saying, less than 40, we wouldn't use morphine. It's advisable not to, but that is not, in Western world, we've got another opioid called oxycodone, which is sort of better, slightly safer than morphine. So what the advice is, if EGFR is less than 40, till EGFR less than up to 10, we use oxycodone there. It's still not absolutely safe. And if EGFR is less than 10, then what we say is fentanyl is a drug of choice. So this is but there's a practical problem in India because morphine is the cheapest option available. Fentanyl is expensive, again, not available everywhere. Oxycontin is not available at all in India. So what we normally say is if only morphine is available, then you can use morphine, but you use in a reduced dose and use an increased frequency. So normally the short-acting morphine lasts for only 4 hours. So you give dose every 4 hours. But if patients has got renal failure, then you don't even have to give it every 4 hours. It can accumulate in the system. So it has to be a trial and error thing. You trial it on the patient, see whether they become more sleepy or not, and if the symptoms get better, like a morphine trial, and then give morphine. Sunil?
Yeah, I agree with you, Sunitha, because we have to consider our situation also. So even though morphine is, some literature says morphine is contraindicated in patients with renal failure, but we have to consider our situation where most of the palliative care units have only orally available morphine. Fentanyl is available as injections and patches, but as Sunitha told, it is costly and injections are not available in many of the palliative care units. So morphine has to be used as even I had a patient who was undergoing hemodialysis, and he was taking morphine once a day, once 5 milligram per day, and that will remain in the system until the next dialysis. So we have to load every time once before after the dialysis. So morphine can be used in our situation, but we have to be careful. Can we use tramadol, fentanyl patch? Okay, tramadol is
Transdermal fentanyl patch.
yeah. Oh, sorry, transdermal fentanyl patch. Yeah.
Yeah.
Yes,
so
Sunitha.
that is so actually transdermal fentanyl patch is the drug of choice for CKD patients. So if that's available and the patient can afford it, definitely. But always, but the problem with patches is if you're using it for pain, patches. If a patient has got acute pain, then patch is not a first line option because patches will it needs some time to start working. So patients are very severe pain. Putting a patch on, especially fentanyl, at least it takes 12 to 24 hours to reach a peak level, and then after 3 days you have to change the patch. So once it reaches the peak level, then every third day you change the patch, and then it's fine. So what ideally you should do is you should give a short acting opioid. And see how much the opioid requirement. So suppose you put them on morphine, again very low dose, see how much dose of morphine he needs, and then you can convert that to a patch. So basically put the patch on, continue the short acting opioid for at least for 12 hours, then you stop the short acting opioids and give it SOS as needed, and by the time the patch will start working. Or you could, if the patient is admitted, you could start IV fentanyl infusion and then gradually reduce the dose, put the patch on, and gradually, after 6 hours, completely stop the infusion, then see how the patch starts working. So patches is not, so the question was dyspnea in CKD patients. Again, fentanyl, the studies that have been done for dyspnea, the opioid is only for morphine. But if fentanyl is the only one available, patches, again, I don't think, I haven't tried. To be quite honest, I haven't tried a fentanyl patch for dyspnea in CKD patients. But, theoretically, it's an opioid, it should work. So again, for dyspnea, it's ideally the better one would be for short-acting morphine, very low dose. But if you're really worried about sedation and the patient can afford, then you can try a low dose fentanyl patch, maybe 12.5 microgram or something you can try. Sunil?
Yeah, the problem with transdermal phenyl patch is that we will not be able to titrate the dose. If you put a 12.5 microgram patch, that means 12.5 microgram per hour will be released. So you will not be able to titrate. So it is good to have short-acting opioids which can be titrated, so that then you can convert it into sustained release morphine or something like that.
There's other question about patient advanced COPD terminal stage of disease. He has troublesome nicotine addiction, not responding to NRT, asking if he can be allowed to smoke during his last days. The general advice about smoking and is if it's cancer patients and they've already got a cancer, then you don't tell them to stop smoking because there's no point. But the problem with COPD is, again, this can be it can be varies with the clinician. The COPD itself, smoking itself, it can make the symptoms worse, and he can become more breathless. So I suppose you should advise him not to smoke. But as you mentioned, if it's a troublesome addiction and if it's causing him more distress, then I suppose you just it's for the best interest of the patient. You just let him smoke. I mean, in hospice and all, we do have smoking areas so patients can go and smoke. So we do encourage that in palliative care, but I don't know how right it is. What do you want to say, Sunil?
Yeah, I agree with you. If the patient is in the last days of life, I would give him even I will get him some. So because that's the last thing that we can do. And even after he become breathless, we will have to manage by giving opioids, and if needed, we have to sedate the patient if the breathless if he becomes such in respiratory distress. Okay, thank you. I think we will move on to patient story, so which will be presented by Dr. Sandhya. Rajlakshmi.
Hello.
Yes,
Hello.
Doctor.
Yes.
Start your presentation.
Yeah. Yeah. Am I audible? Hello.
Yes, you are.
Okay. So, good evening, everyone. So, next slide, please. My case is, it's an 82-year-old male patient, and the diagnosis is acute right frontotemporoparital SDH, subdural hemorrhage, with tendorial SH, subarachnoid hemorrhage, obstructive uropathy, Parkinsonism, type 2 diabetes mellitus, systemic hypertension, benign prostatic hypertrophy. Next. Yeah, the presenting complaint include history of fall at home 3 days back and altered sensorium 1 day back. Next slide. So the patient was apparently normal 3 days back when he suffered a slip and fall with loss of consciousness for a few minutes at home, following which he developed 3 episodes of vomiting 6 hours later. There was no history of seizures or ENT bleed or other injuries. Since one day, his wife noticed patient to get less responsive and inability to walk. And the patient is a known case of diabetic on oral hypoglycemic agents and insulin. He's hypertensive on telmisartan and H. He has Parkinsonism on LCD, levodopa carbidopa. He has benign prostatic hypertrophy on prazosin and tamsulosin. And he has a history of old CVA 20 years back. Since then, he is on aspirin. And but the history is not clear about this CVA. But they are saying that after that he was okay. So maybe it is a thrombo TIA. Next slide, please. And on examination revealed, he's an febrile patient with heart rate of 70 per minute, BP 180 by 100 millimeters of mercury, respiratory rate of 20 per minute, saturation of 95% on room air. He was conscious but confused with the Glasgow coma scale of E3, V4, and M6. He was moving all 4 limbs, pupils equal and reacting to light, plantar bilateral flexor, and he has cellulitis changes in bilateral legs. All other systems were normal. Next slide, please. Next slide, please. Yeah, so his CT was taken and it showed an acute right frontotemporoparital SDH with no significant midline shift. There was tentorial subarachnoid hemorrhage, and the repeat CT after 6 hours also showed there was no increase in hemorrhage. His significant investigation findings include a sodium of 128 milliequivalents per liter, but we didn't treat that because we usually treat serum sodium when it is less than 120 milliequivalents per liter. And his RBS was 239 milligram per deciliter, potassium of 3.3, and other investigations were normal. And he was admitted in ICU. And we managed him with, his aspirin was stopped since this is a hemorrhage, and his hypokalemia was managed with syrup KCl because he was taking orally, and he was given injection levetiracetam, Tranexa, injection Pandope, and there was improvement in the Glasgow coma scale, but there was generalized slowing, could be because of his Parkinsonism, and oral feeds were started. The patient was self-voiding, but we noted a decrease in the urine output, and on ultrasound examination, it showed a bladder distension. And we tried catheterization, but it failed, and the urology consultation was done. And the urologist also tried bladder police catheterization, but it failed. So suprapubic catheterization was done under local anesthesia for stricture urethra. And as I said, he has cellulitis changes in the bilateral legs. And on examination showed healed scars and areas of hyperpigmentation. There was no redness or warmth. So the surgery consultation was done, and the surgeon advised regular emollient, saline compress, and Fusibet ointment. And he was shifted to the room on the on fourth day. And at the time, his GC was 15/15, but there was generalized slowing. But on the next day, he was shifted back to CCU because the ward sister noted that there is decreased responsiveness. And when we examined him, he was hemodynamically stable, but GCS was slightly less, E3, V4, M5. Next slide. And we again took a repeat CT brain. We showed no significant changes other than the initial changes. There was no midline shift. We took EEG also because whether we want to know whether it is because of the seizures. So there was no seizure activity at that time, and the other investigations were normal. But on that day, when he came back to CCU, the GCS was waxing and waning. So we started him on RT feed. And after that, within 2 days, he became normal. Means his GCS become 15/15, even though there was generalized slowing. But we tried oral feeds with RT in situ, but he was coughing. So we continued with him with RT feed, and his SPC was in situ. So after 2 days, he was shifted back to his room with RT and SPC in situ. So psychosocial factors include he belonged to a middle class where he's living with his wife who is elderly, who has diabetes, all the elderly problems, diabetes, hypertension. She also had a history of COD, and he has 2 daughters who are married and both are homemakers. Next slide. Next slide, please. Yeah, so the medications include, as I said, aspirin was stopped. He was managed with Levipil, Tranexa, Pantob, syrup KCL, and insulin was given according to the sliding scale. Other medications which he was taking was continued, like LCD, Prazosin, Tamsulosin, Telmisartan, etc. Next slide, please. So the main concerns for this patient after he was shifted to ward include his care of bowel, bladder, and skin. Because he was suprapubic catheterized, so we have to manage in that way. Then care of his RT and RT feeding, and he has financial issues because usually we discharge him with this one, and his family has to manage all these things, and we don't think that he has the financial stability to afford a home nurse or something. Next slide, please. So the summary include 83 2-year-old gentleman with past history of hypertension, diabetes, BPH, old CVA, presented with history of fall at home, and presented with altered sensorium. CT scan showed acute frontotemporoparatal SDH with tentorial SH, managed with neuroobservation, Levipil, Tranexa. Suprapubic catheterization was done for stricture urethra. There was cellulitis changes in the bilateral legs, managed with emollient and Fusibet ointment. He was shifted to the room on 4th day in a stable condition, but next day shifted back to CCU with decreased response. And the CT brain repeat CT showed no significant changes, and other investigations were normal. And he got improved, and shifted back to room after 2 days in a stable condition with RT and SPC in situ. Next slide. So the discussion points include care of bowel, bladder, and skin, care of RT and RT feeding. So thank you so much.
Thank you, Dr. Sandhya, for this excellent patient story. So, are there any doubts regarding this patient story? Was he ambulant before the fall?
Before the fall, his wife said that he will walk very slowly, but he walks actually, but very slowly.
Okay.
That's what she said. But after the admission, he was not at all moving. Means we were made him sit in the bed,
Mm.
but we couldn't ambulate him actually.
Okay. Okay. So anybody from the participants, can you? Yeah, Dr. Sandeep Kumar asked if sodium correction was considered.
No. We correct sodium only if it is less than 120 milliequivalents per liter.
So Sunitha, what's your comment on that?
Sorry, what value do they correct sodium?
Sodium was 128. Yeah, 120, isn't it?
128. We will correct the sodium usually when it is less than 120 milliequivalents per liter.
Okay,
And if
okay.
there is any symptoms of hyponatremia,
Okay. Yeah,
this
yeah.
patient, this condition is because of this hemorrhage, not because of the
Yeah, yeah.
hyponatremia. Yeah, that's why we didn't correct. But we were giving him normal sodium, normal saline, NS, 0.9%. So that is okay.
Yeah,
And the repeat
I
sodium was
agree
normal.
because his symptoms are not due to low sodium, right? So probably there's no point in correcting. Yeah.
And the bystanders were actually very anxious. How will we do this RT feeding? How will we care this SPC and everything?
Yeah.
The other thing that I wanted to ask was, do you all, when you see hyponatremia, how much do you investigate? Like, do you all try and do the osmolality and try and find out the cause of hyponatremia? You just do like blindly correcting? You do?
No. We'll do this osmolality and everything. We will find out what is the cause. Is it because of the drugs? Is it because of vomiting? He had vomiting.
In this patient, was it found out? Do you know?
Sorry?
In this patient, was that done? Do we know what's the cause of hyponatremia?
Actually, this is 128. After giving normal saline, it came back to normal.
Oh, right.
So it was
Okay,
not
fine.
a
So only
severe
one value. Fine.
Yeah,
fine.
one value only.
Okay.
Yeah.
So anybody want to comment on her discussion points? How do you take care of the bowel, bladder, and skin? I'm sure many of you might have seen patients who is bedridden and need to do all the care. Anybody? Shiba, have you joined? Rajalakshmi, can you see Shiba?
Yes, sir. Yes, sir.
Okay, so I think we will ask Shiba, who is the training coordinator here and was the nurse in charge who was working in palliative care for more than 20 years. So we are getting many patients who are bedridden. So basically we have to give good nursing care. So Shiva, can you talk about how to take care of bowel, bladder and skin and Ryle's tube, etc.?
Sister Shiva, we can't hear you.
Hello.
Yes, Shiba, speak loudly.
Hello.
Speak loudly, speak loudly.
Can you hear me now?
It's very feeble.
Hello.
Yes, sister, we can hear you, but it is very feeble.
What about now?
Same.
Hello, sir. Can I join with my mobile phone? Then I will try. Hello.
Hello?
Hello, Rajlakshmi.
Yes, sister, it is clear now. You can continue.
Oh, okay. This patient. Hello.
Yes, we can
Yes,
hear you.
continue.
Yeah.
If patient seems to be bedbound, so the patient is prone to develop pressure ulcer. So skin care is very, very important for this patient to prevent the pressure sore prevention. So the first thing you have to tell the patient and caregiver about to prevent how to develop pressure ulcer. So continuous constant pressure is if you apply the same position, the constant position is there, so that will the disrupt the blood supply and then damage the skin. So you should tell the caregivers and the patient the importance of changing your position. So you have to change the position every 2 to 4 hours. And you can tell you can provide water bed or air bed for that this type of patient to prevent pressure ulcer. But you can tell them if the patient is on water bed or air bed, so still you have to change the position. So otherwise, this water bed and air bed is give some pressure relieving. The that will act as a pressure relieving technique. So that is not 100% pressure sore prevention. Even if the patient is in water bed or air bed, you have to change the position. And daily skin inspection. When they change the position, every 2 to 4 hours you have to change the position. When we change the position, you have to check the skin. So if there is any change, the color change there, you have to give a special attention on that area. You can prevent further pressure on that area. So that will prevent the damage of the skin. And when we change the position, you have to apply moisturizing agent oil or any Vaseline or liquid paraffin over the skin that will improve the application. And the fourth thing, there are three major causes of pressure. One is pressure, moisture, and the third one is friction. So moisture, here is the patient is bedbound, the incontinence of stool will be there maybe. So if there is a motion, the patient will pass the motion, they have to change the sheets as soon as possible. Otherwise, skin will damage and there's a chance of developing pressure. The maintaining of good nutrition also. So protein intake is also very, very important. And every day they will change the sheet. So when they change the sheets, when they have to turn the patient well, and then they have to change it. When we pull the sheets under the bed, there is a chance of friction and develop pressure ulcer. So that's in the skin care. And rights to feeding. And here we know when we introduce a rights to the gastroesophageal sphincter is always opened. So before you feed the feed, you have to check the position of the tube. You have to aspirate the food content, and you have to check whether the tube is in the stomach or not. And position. So you have to semi-recommend position at least 30-degree the head and elevation is must. Otherwise, after the feed, what happened is when the patient is regurgitate, that stomach contents will aspirate and the patients will develop aspiration pneumonia. So here is the position is very, very important. And every feeding, the hand hygiene is very, very important. You have to tell the caregivers before they are feeding, they have to wash the hand with soap and water. Only they have to feed. And the patient is on rights to, nobody is bothered about mouth. So mouth care is also important. So you can tell them clean the mouth every 4 hours. And they can give any food. So you can any food. So usually they when the patient is on rights to, they depend on the tin food. So you can tell them any homely available food they can give. and check the patency also. After the feed, they have to maintain the position at least 1 hour. Then they have to keep the patient in supine position. And SPC care, uh, this is one of the foreign bodies, no? So there is a chance of the developing infection. So oral intake is very, very important. Especially in the SPC, suprapubic catheterization, there is a stoma is there. So stoma care is also important. Here also hand hygiene before they clean the stoma that around the suprapubic area. They have to wash the hand with soap and water. Then only they have to clean the stoma. And when they clean the stoma, they can use normal saline to clean the wound. And they can keep the urinary bladder below the level of the bladder. And you can tell them if there is any signs of infections, rainy redness or excoriation of skin there, they can apply zinc oxide powder. So you can tell them if they have any problem, they can inform you, and then you can, based on their problem, you can treat them. And this and when the patient is on catheter, the bowel management is also very, very important. So bowel management for a bedbound patient, there is a chance of developing constipation. So bowel manage every alternate days. They have to move the bowel. So any non-pharmacological management is also you can try, and if failed, you can give some medicines. And if the patient is constipated, you can do a PRE and find out whether the rectum is loaded or balloony rectum. If the rectum is loaded, you can remove manually, and you can give enema, sodium phosphate enema you can give. If the bowel is balloony, you can give a higher enema. So, sir, anything?
Yeah, thank you, Shiva. Sunitha, do you want to add anything?
No, Sunil. I think that was comprehensive.
Okay. So, any of you want to add anything?
There's a question here about will PEG tube be considered in this patient?
How often you consider changing Riles tube?
Riles tube.
So what's your policy, Sunitha, in general hospital?
I think we just there's no different criteria. What I've read is you can't leave it more than 12 weeks. I'm not sure about this, but definitely in GH it goes more than that, because obviously only if it comes out or if it becomes too dirty, and you can if it needs to be changed, then only it gets changed at home. Yeah.
Yeah, we also practice the same thing.
I'm not sure entirely how the guidelines are, and
but
even
I haven't seen any guidelines on this, even though I have searched.
Okay, yeah. So
but some hospital advise to change Riles tube every month.
Every month, okay, yeah. Because there is a concern that you could probably have some bit of stenosis and stricture, right, if it's there for a long time. But PEG, again, for this patient, this patient that Dr. Sandhya presented, is it a reversible cause of this? Is the solo going to come back or not? So should we be considering PEG or not? I think that's a very good question. Did your team of doctors think about that, Dr. Sandhya?
Sorry, doctor, I didn't get actually.
What about PEG feeding? Was it ever considered for your patient?
Actually, no. Because in ICU, we will just shift the patient to the room. And the other case, the remaining is managed by the primary physician. Because this patient is admitted under the neurosurgeon, so he will, like that only.
Okay.
What do you think his prognosis, Dr. Sandhya?
what the neurosurgeon said is he will be like this only because he has Parkinsonism, he has this hemorrhage and everything, and he's 82 years. So we have to continue with all these things and like that.
Okay. So Vaya asked us if he has a long term, if he is going to survive for long term, then PEC can be considered, but we have to also ask the patient if he can understand, take his consent before doing anything. So I'm not sure whether PEG is indicated in this patient. He has multiple comorbidities.
Yes. Yeah.
Okay. So any more questions? So thank you, Shiva, for this coming out with nursing help that can be done to this patient. So for all bedridden patients, it is very important to manage bowel, bladder, and skin. And many patients will have Ryle's tube and catheter also. So this is something which we have to teach the family member. Otherwise, they will. So many patients from other hospitals comes to us to learn how to care for these things. So that's very important. We have to teach the caregivers. And thank you, Dr. Sunitha, for your excellent session. Thank you, Dr. Sandhya, for this good patient story. And thank you all. Rajlakshmi.
Thank you, sir.
Sir, Dr. Sunitha have left, sir. So
Yeah.
Dr. Sunitha have shared a feedback link. I request all to do it. And also we have shared our echo feedback. So kindly do attend both the feedbacks. I can share it in our group too. So we can see you next week with a session on gastrointestinal symptoms. Thank you all for joining in. Bye. Very nice.